In this video, we are going to talk about the facial nerve anatomy. We were talking about Bell's palsy in the last video. If you're not seen, go see the video. Bell's palsy is something when your facial nerve getting inflamed and you lost the ability of to move your facial muscles on one side. So related to that, we were talking about the facial nerve anatomy. So facial nerve actually it exists to a small foramen in this area called stylomastoid foramen, and it comes and give different branches in the face. So first we will talk about the different branches of the facial nerve. The first branch in this area we call it as the temporal branch, because we call this area a temporal region. So this is this area we call it as the temporal region. Then this eye area, this area we call it as the zygomatic area. So we call it as zygomatic branch. So the first branch is temporal, the zygomatic branch, and the third branch is here, buccinator muscle. We already saw in the last video muscles of the facial expressions. So this area it comes to the buccinator branch. Then it comes to the this mandible area, that is marginal mandibular branch. Then the last branch comes in the cervical region, which is the cervicular branch. These are the peripheral branches of cervical nerve, the terminating part, the ending part. But when you see the deeper part, the inside, what is happening from where the brain, that point, brainstem, it is out coming out. All these factor you need to see a deeper thing. So different branches, the basic branches of the facial nerve, the temporal part, the zygomatic, the buccinator, the marginal mandibular part, and the cervical region. Same for this. So about these area there is a foramen called stylomastoid foramen, and through that area the facial nerve exists and give different branches like this and this side also. So now let's see the deep picture of the facial nerve. You see, stroke and facial paralysis is two different things that you need to be identify. You should be able to identify the two different things. When you see a stroke patient, usually their upper part will be not involved. In other words, there won't be any loss of motion in the upper part. They can lift their eyebrows, but in the lower part they won't be able to do. But in Bell's palsy or facial palsy, the entire region is lost. Now, why is that? Let's see the anatomy. Facial. This is the this is a map of facial nerve actually. So the facial nerve is not just supplying our facial muscles, right? It's just not supplying our facial muscles. This is just the motor branch. There is another branch that very important that you need to understand is one of that sensory supply is to the anterior two-third of the tongue. The taste sensation that you is called from a branch of the facial nerve is called a chordae tympani. So that branch from the facial nerve is going to give a supply to the anterior two-third of the tongue. This anterior two-third of the tongue, this area you are getting sensation from the facial nerve. So if you get a facial nerve palsy, you might lose taste. So that branch is supplied by chordae tympani. Chordae tympani. That branch of facial nerve is called chordae tympani, but that is coming in this area. This area it will come. Then one of the sensory supply is back posterior part of our ear. That is one of the sensory supply of facial nerve. So the first two sensory part you need to know is that anterior two-third of the tongue, which is by chordae tympani. The posterior part of my ear is also supplied by facial nerve sensory branch. Right? Other moving muscles are motor branch. Now other muscles, very important muscles supplied by the facial nerve is posterior belly of digastric muscle. Digastric muscle will come in this area. So digastric muscle will be coming. This is anterior belly, this is posterior belly. This muscle here is posterior belly of digastric is supplied by facial nerve, which is helping us in chewing and swallowing food and all that might get affected because of facial nerve palsy. And this next one is stylohyoid is coming in this area, which is also helping in chewing, eating food. That might also get affected, and which so the facial nerve is supplying them also. So one is this is motor branch, okay, posterior belly of digastric, stylohyoid, and other thing is called stapedius muscle is there. What is the function of stapedius muscle? If you see the function of stapedius muscle, basically stabilize the stapes bone is there, which is, so once you lost that balance, the stabilization of the stapes bone, even a normal sound you hear that may increase into you hear like a loud noise, so it started to irritate you if you have a Bell's palsy. So these are the motor branches. Other motor branches you need to focus on: posterior belly of the digastric, stylohyoid, and stapedius muscle. Because stapedius muscle is getting affected, stapes bone cannot be stabilized. Because of that, normal voice, normal sound will be heard as loud noise, which started to irritate you. Now, what is the difference between stroke and Bell's palsy when it's affecting the face? If you see here, look at that red line coming here. Okay, this red line only you see. Red line coming here, coming into the. This is a brain. This is brain stem. This is a facial part, right? If you see that it is coming and coming through the. This is the stylomastoid foramen. Stylomastoid foramen. This is the area where usually when you get Bell's palsy get inflamed. This is the part where it get inflamed. So the nerve is coming from here, giving it all the way. From the brainstem it comes, and then it comes to the face. Now if you see, when you have Bell's palsy, where it is getting affected? It is getting affected here in the peripheral part. But when you get a stroke, where is it getting affected? It is here. And when you get a stroke, usually if this side is affected, the contralateral side will be you lose the muscle force, or the strength is lost usually in the contralateral side. So what happens here? But if you have inflammation here and this get imaged in the stylomastoid foramen, what will happen? This same side will be lost. Stroke opposite side will be lost, right? That is one difference. The other difference is, if you see the upper part is supplied by the same side, the red side. This is the contralateral side, the red side, red marking. See the upper part, this part only you see. The upper part is by contralateral. At the same time, ipsilateral is also supplied. So what happens if you had a stroke here? You will lose complete part of the lower part muscle force. You will completely lose, because only the lower part only supply from the contralateral. Let's say this part you get stroke. See the red line. Red line is supplying. The full red line is supplying the lower part. So if you get a stroke, you will lose complete loss in the lower part. But in the upper part, there is not only red, there is blue is also there. Blue is from the ipsilateral side, from the side. This side stroke is not affected. So usually what you see, this side upper, the patient can move the upper part. The person can actively move the upper part, cannot move the lower part. That is usually what stroke. Why? Because when you have an injury from this area, this ipsilateral side also supplying the upper part. So there is a contralateral supply to the upper part and ipsilateral supply to the upper part, but to the lower part only contralateral. So if you get a stroke here, you will lose the control over here, but you can actively move the upper part, from the eyebrow raising and all you will be able to do. But let's say you have a Bell's palsy, which is inflammation in the stylomastoid foramen. What happens? This part there is inflammation, this is cut. Now will you be able to do the upper portion and lower portion? No. That is why you are losing both upper and lower part movement in Bell's palsy. This is a thing actually you need to understand regarding the Bell's palsy. See, the contralateral side is supplying the lower part. The upper part is supplied by the ipsilateral, red color, and the contralateral. That is why you need to understand, to see a patient who is coming to you, or you are a patient who is suffering, that's feeling like you can move the upper part but the lower part is not affected. That might be a stroke.